For my case study, I'm going to present to you a case study of central sleep apnea. For my patient, his name is Mr. Joey. He is a 68-year-old male with a history of chronic systolic heart failure with an EF of 30%, AFib, and chronic opioid use for spinal stenosis. He presents to the sleep clinic with complaints of persistent fatigue, frequent nighttime awakenings, and waking up short of breath. The patient denies choking or gasping during sleep, but does admit to feeling unrefreshed in sleep. He has difficulty staying asleep, and he falls asleep throughout the day. He previously failed CPAP therapy due to discomfort and no improvement in symptoms. For our objective, we have his vitals we took, and his blood pressure came back normal at 104/68. His heart rate was 62 BPM. However, it was irregular, consistent with known AFib on his EKG that we conducted. His respiratory rate at the time was 12 breaths when we were doing the physical. His temperature was 97.8 degrees Fahrenheit, and his SpO2 on room air was 90% at rest, but when we were doing the sleep study, we saw that it dropped to 86% during his sleep. With his physical exam, we determined upon auscultation mild bilateral crackles at the lung bases. We saw jugular venous distension, and again, an irregular heart rhythm, an S3 gallop. We saw that there was no significant upper airway abnormalities when feeling or neck thickening as well, even on his CXR. For the polysomnography test, we had an AHI of 32 events every hour. 90% of the events were determined as central apneas. There was Cheyne-Stokes respiration present, and his oxygen desaturation index was at an 18. His lowest SpO2 when we did the polysomnography was an 84%, and his ABG on room air at 1 a.m. we got, and it came back as 7.47 for his pH, a PaCO2 of 31, a PaO2 of 58, an HCO3 bar carb of 21, and an SaO2 of 88%. For the AA gradient and PF ratio calculations, I did the formula and I got 110.98 millimeters of mercury. For my AA gradient, I got a 52.98 when I took my PaO2 110.98 and subtracted it by 58, which is the PaO2 or P(a)O2, and I got 52.98 millimeters of mercury. So a normal AA gradient would be 21 millimeters of mercury. So this patient's gradient is definitely elevated, which indicates a diffusion defect or VQ mismatch, despite the patient having an open airway. In central sleep apnea, the issue is not anatomic, but functional, with failure of ventilatory drive, which leads to inadequate alveolar ventilation. For my PF ratio calculation, I took my PaO2, divided it by my FiO2, 58 divided by 0.21, and I got 276. For normal range, it would be above 300. For mild hypoxemia, it's going to be between 200 to 300, which that PF ratio falls under that category. and moderate would be 100 to 200. Severe would be less than 100. This patient definitely has mild hypoxemia, consistent with no airway obstruction, but insufficient ventilation due to that absent central drive during the patient's sleep. Now, for the assessment, I can make the conclusions based on these interpretations that the patient is experiencing primary central sleep apnea, a Cheyne-Stokes type, likely secondary to chronic systolic heart failure and opioid-related central suppression. Now, my findings that I got that correlate to this interpretation would be a high HI with predominantly central apneas on the PSG, which is the polysomnography tests we did. I also saw Cheyne-Stokes respiration pattern for that as well. The patient does have an elevated AA gradient with mild hypoxemia that we got from our calculations. The ABG that we got at the 1 a.m. mark did show a respiratory alkalosis because there's a low PaCO2 and an elevated pH, which is consistent with hyperventilation phases during that periodic breathing at night. There's underlying heart failure and opioid use, which are known central sleep apnea triggers or symptoms, as well as signs and symptoms, like we reviewed in the previous slides. So, in conclusion, the patient's central sleep apnea results from brainstem dysregulation of ventilatory drive, which likely worsened by cardiogenic feedback loops and chronic opioid-induced respiratory depression. So unlike obstructive sleep apnea, the airway remains open, but there is no central stimulation to initiate the breath, leading to hypoxemia, poor sleep, and cardiovascular stress. Now, for his plan, what we want to do for his care plan would be sleep therapy. We want to try ASV, which is adaptive servo ventilation. The mode would be auto-adjusting pressure support with fixed EPAP. The settings for EPAP, we're going to start him on 5 centimeters of water pressure and a PS range of 3 to 15 centimeters of water pressure. The goal would be to maintain a stable minute ventilation to prevent both central and obstructive events. And the purpose would be ASV supports spontaneous breathing efforts, reduces central events, and adapts in real time to unstable ventilation. Now, some medications that we can do are the patient is currently on oxycodone, 20 milligrams BID, so we want to initiate a slow taper, switch to a non-opioid pain management like acetaminophen or physical therapy even. We want to get them off of those opioids under like pain management supervision. We also want to optimize heart failure management by giving furosemide 40 milligrams PO/BID. This is a loop diuretic to reduce that pulmonary congestion and improve ventilation perfusion matching. We could also give carvedilol 12.5 milligrams PO/BID. This is a beta blocker for rate control and neurohormonal modulation in HFrEF. We could give lisinopril 10 milligrams PO daily, which is an ACE inhibitor to improve cardiac output and reduce remodeling. We can also monitor electrolytes and renal function weekly as well. We can do for monitoring a serum BNP and echocardiogram in 4 weeks to reassess cardiac function and monitor for signs of opioid withdrawal or pain flare-ups during the tapering. We also want to make sure to educate our patients and support them. It's important that we are a support system for our patients. We want to educate this patient and the spouse on central versus obstructive sleep apnea so they know the difference. A lot of times people know about obstructive sleep apnea, but they aren't too sure about central. So just having the patient know the difference between the two can be helpful. We also want to discuss the importance of adherence to ASV and avoiding those sedatives. We can refer them to cardiology and pain management as well, and give them sleep hygiene counseling, like giving them, for instance, like a consistent sleep schedule, or let them know not to take in caffeine at night so they get a better night's rest. So this patient has central sleep apnea, and it's driven by impaired respiratory control in the brainstem, which is also by the heart failure and chronic opioid use. The elevated AA gradient reflects that functional gas exchange abnormality due to ventilation irregularity. And the mildly reduced PAF ratio indicates the sufficient oxygenation during apneic episodes. The treatment plan focuses on helping him basically address those issues, and it's important that he adheres to it so he can get a better night's rest and be able to sleep better, which will be better for his heart and cardiac function as well.